Hey guys, welcome back to another 5-minute frenzy with Ryan Gopinski. Today's topic is going to be the terminology related to invasive ventilation. Now, this is not all encompassing, but if you understand these terms, you'll be well on your way to understanding mechanical ventilation. If mechanical ventilation is something that you do on a regular basis, then this is one that you should probably skip. I think that it's important to spend the first 30 minutes or so of this presentation on the oxyhemoglobin dissociation curve. But since I only have a few minutes, we're just going to skip this one. So real quick, this is a overview of the terminology that we're going to be discussing today. Tidal volume, simply put, is the amount of air delivered with each breath. This equates to approximately 8 milliliters per kilogram of ideal body weight in a normal, healthy individual. That is, someone that's awake, alert, active. This is not necessarily the setting that we'll use in a ventilated patient. Vent settings for tidal volume will vary based on disease process and patient need. Expired tidal volume is the measurement of the amount of air that a patient exhales with each breath. This is an important parameter to keep an eye on to ensure that the patient is not breath stacking or retaining air in their lungs. Each breath generates a tidal volume at a set rate, the quotient of which is minute volume. Carbon dioxide levels in the blood generally vary inversely with minute volume. For example, a person with increased minute volume due to hyperventilation should demonstrate a lower blood carbon dioxide level. The human body will alter minute volume in an attempt to maintain physiologic homeostasis. A normal minute volume while resting for a normal individual is about 5 to 8 liters per minute, and that generally decreases when at rest and increases with exercise. For example, during light exercises such as walking, the minute volume may be around 12 liters, and that may increase to about 40 to 60 liters per minute with moderate to heavy exercise. Hyperventilation is a term that we use for having a minute ventilation that's higher than physiologically appropriate, and hypoventilation describes a minute volume that's less than physiologically appropriate. The relationship between minute volume and PaCO2 is not linear. In patients with hypoventilation, for example, small changes in minute volume can drastically reduce PaCO2. Inspiratory time, or I time, is the length of time over which one breath is delivered. This can range from 0.3 seconds all the way up to 1 to 1.5 seconds, depending on the age of the patient and the physiologic reasons that they are being ventilated. Expiratory time is just the opposite. This is how much time the patient has to exhale. This is the same as the length of time between breaths. I to E ratio is the relationship between inhalation and exhalation. During spontaneous breathing, the normal I to E ratio is 1 to 2, indicating that for a normal patient, the exhalation time is about twice as long as the inhalation time. If exhalation time is too short, breath stacking can occur, resulting in an increase in end expiratory pressure called autopeep or intrinsic peep. Depending on disease processes, the I to E ratio can be changed to improve ventilation, and in rare cases, such as ARDS, may need to be inverted. Peak inspiratory pressure, or PIP, is the highest level of pressure applied to the lungs during inhalation. Peak inspiratory pressure increases with any airway resistance. Normal patients, when ventilated at normal tidal volumes, will have PIPs of 25 to 30 centimeters of water. However, some patients with lung compliance issues may show pressures of 30 to 40 centimeters of water. Interestingly, one retrospective study has shown that barotrauma occurred in 8% of patients with a PIP of above 50 and 43% of patients with a PIP above 70. The gold standard in measuring pressures of the lungs is plateau pressure. Plateau pressure is the amount of pressure in the alveoli and the small airways during mechanical ventilation. Plateau pressure should always be below 30 centimeters of water. The equation to measure mean airway pressure may look complicated, but if you think about the definition, it'll make sense. We take the inspiratory time multiplied by the inspiratory pressure. Add that to the expiratory time multiplied by the expiratory pressure, also known as PEEP, and divide that by the time it takes for one respiration. This is very similar to the way that we calculate mean arterial pressure using systolic and diastolic blood pressure. On a normal patient with no obstructive disease processes, we would expect a mean airway pressure of 5 to 10 centimeters of water, and in patients with ARDS or COPD, this number can range from 15 all the way up to 30 centimeters of water. Positive end expiratory pressure, or PEEP, is the amount of pressure in the lungs that exists at the end of expiration. A small amount of applied PEEP is used in most mechanically ventilated patients to mitigate end expiratory alveolar collapse. A higher level of applied PEEP, say greater than 5 centimeters of water, is sometimes used to improve hypoxemia and reduce ventilator-associated lung injuries. PEEP is not entirely benign, though, as it can contribute to a decrease in systemic venous return and pulmonary barotrauma. FiO2 is the percentage of oxygen being delivered, expressed as a decimal. For example, 21% oxygen is an FiO2 of 0.21. Typically, in the emergent setting, we initiate mechanical ventilation with an FiO2 of 1.0, or 100%. However, in the critical care and ICU settings, the lowest possible FiO2 should be used to mitigate untoward effects of supplemental oxygen use. Guys, that's all I have for you today. I hope this was good enough for you. Again, this was just a brief introduction to terminology. I'm working on a more advanced presentation of mechanical ventilation, and that should be out very soon. In the meantime, feel free to drop me a line on Twitter at RyanGapinski2, and I'll talk to you all again real soon.